Thank you very much and welcome again, everybody. It's wonderful to see you all again on Zoom and back in this community. We hope you've had a good month and we're looking forward to starting off again this year with this session on communication skills, which is so important in our medical practice and in palliative care practice. I thought I'd just briefly go over the schedule for tonight so that you have an idea of what we are going to be doing together. So initially, Dr. Anil will give a presentation for about 20 minutes or so, and then Dr. Anil and Dr. David will do a couple of role plays on, perhaps not the best practice, and then maybe some better practice in communication. And then we hope to have, we plan to have breakout rooms. So our expert Pallium team will break us all up into groups of about 3 or 4 or 5. And we can spend a bit of time in those groups talking about what we noticed in those role plays with Dr. David and Dr. Anil, and what we thought worked well and so on. There'll be a slide to help prompt that discussion. And then we'll come back and hopefully we'll have plenty of time for feedback to the bigger group from each of the breakout groups, and again, more discussion as a group. So I think it'll be an exciting session, and I'm really looking forward to hearing your thoughts and experiences on, the challenges in communication in your day-to-day practice, or all of us actually, we all have these challenges. So without, and I think you've all seen the slides reminding you of some of the kind of terms of engagement in ECHO. So just, you're already all doing this, keeping your microphone on mute when you're not talking. And if you'd like to contribute in the chat, please do. It's a great way to have some interaction in these sessions. And otherwise, put your hand up, use the reaction little button down the bottom to raise your hand, or physically wave your hand, and we hopefully will see you and be able to get your thoughts. So, and to just introduce yourself in the chat. All the members of this community. So it's my great pleasure then to introduce Dr. Anil Tandon, who's an experienced palliative care physician in Perth, Australia. Anil has been involved in Project Hamrahi since it started in 2011, I think was your first trip to Jamshedpur, and he has since been involved in Hamrahi links in Mizoram and also in Jaipur and in Kolkata. So Anil has a very wide experience of palliative care practice both in Australia and in India through the Hamrahi experiences. So over to you, Anil. We look forward to your presentation.
Thank you, Odette. And can I just test, can someone indicate that my voices are audible to you? Thank you. So when Odette was, and the rest of the APLI team was setting up the initial thoughts about this series of ECHO Hamrahi sessions, some of the feedback that we had received was to have a session on difficult conversations, and in particular, the approach when family members are angry. That is therefore part of what I would like to cover today. You should have all hopefully received the email sent out in the last day or two with some journal articles. So they weren't necessarily pre-reading that was required for today, but more something that you can use down the track, hopefully. with communication skills training, there are many different theoretical principles that are used. There are many different teachers, expert teachers. And so what I have sent around is just 2 examples of a couple of techniques that certainly I find very helpful. And so there's both the detailed journal article, but also just a briefer 1-page summary of some of the core principles that are used. In all of these articles, though, and anything that you find online, it's important to remember that communication is very culture specific. And so often you will see examples being given of phrases that, you may want to use. Take that and obviously incorporate it into both your culture and the way and your language, but also for what is going to feel natural for you as an individual. And so there are many techniques that I've been taught by experts who I greatly respect, but are not necessarily they're not phrases that I might use or would come naturally, because clearly what we need to do is come across as being authentic. So the objectives for today. Now, what I want to do is share my screen just so that you can then see, hopefully. Now, can I just confirm that that is being seen by everyone? I actually have now lost the so can someone just actually say yes to me so that because I can't now see any of you.
We are yet to see your presentation, sir.
Oh, wonderful, thank you. So the objectives for today, really I would like to just introduce this concept that some of you may already be familiar with, called goals of care.
And then we are sorry to interrupt, we are not able to see your presentation.
Oh.
Try again, Anil. It may be that you hadn't got the sharing permission.
Because I hadn't clicked the correct button. So with the process of goals of care, what we're trying to do is align effectively 2 parallel frameworks. So we're all very familiar with the biomedical model of, as doctors or nurses or allied health professionals, we're very clear on this is the person's diagnosis, these are the symptoms that they may be experiencing, the signs that are present on examination, the investigation results, and what in effect is the underlying pathology. But there's another very important perspective as well that is very easily ignored, and that is the illness perspective, or what is the experience of the patient. And so from that, although part of it may be the symptoms that they're experiencing, it's trying to get at a deeper level of who they are as an individual with this illness. So what do they think is going on? What are they concerned or worried about? What are they hoping for in the future? Or even what are they hoping from this appointment in the outpatient clinic with you, or this hospital admission? How is the illness affecting them either emotionally or on their ability to conduct their daily activities? And so the way that I frame it in my mind is that whenever I'm going into this conversation where I want to discuss at a more deeper level what is occurring for this patient, either with the patient or with their family member, I try to keep at the forefront of mind that there are 2 experts in this conversation. I might be the expert in their disease, but absolutely and always they are the expert in themselves. What is important to them? What are their values and wishes? And it's only if we can accept that there are these 2 experts together, and that each of us needs to hear the other person, that we can come to some shared understanding and then a way to move forward on what decisions have to be undertaken. So the second objective for today is following the feedback that we had received, was to look at how would we respond to an angry patient or family member. So what would be some of the key things that we would like to look at? So often we're very time pressured in not just in these types of conversations, but in our daily work. And so trying to utilise our time as efficiently as possible. So investing in the beginning of the conversation is very important. Secondly, keeping in mind the patient as an expert or the family member as an expert, very much realising that the goal of this conversation is not just for me to convey information to them, but absolutely for me to understand where they are coming from. What is their perspective? Thirdly, it is the non-verbal, the softer skills of medicine or healthcare. And so in particular, trying to show that we're genuinely concerned about the patient in front of us. And then finally, investing in the end, because what we need to do is we need to have good skills of how are we going to draw this discussion to a close, where hopefully they will feel that they are heard, but secondly also that you have an outcome that you can then work on. So investing in the beginning really requires that we need to develop rapport very quickly. And so clearly we will all have our own techniques in that, in a communication, a conversation where we're communicating serious news and trying to have some form of plan about where we go to next. There are a few things that will be required. Absolutely, they will need to understand, the person that we're speaking to, that they have our full attention, that we're not distracted, and that their problems and the best outcome for them is absolutely the highest priority for us. We need to remember that trying to understand what their agenda is will be the first component of the conversation. And so although we may go into this conversation thinking that there are certain things that I need to make sure that the patient is told about, for example, that the scan shows that the cancer has progressed, or that there is no further option to give another blood transfusion, whatever that may be. Before we get to that point, we have to understand, well, what are they worried about? Because it's only once they have had the ability to be heard that then they will be mentally in a space where they can then hear what you have to say. Letting them know what to expect. So it might be as basic as how much time have you got for this conversation? Or if you're expecting an interruption, and ideally we don't want to be interrupted, but if you're expecting an important phone call, you can say, I'm very sorry, I might be interrupted by this. So how do we get the patient's perspective? So it will be important to remember, if you can, this acronym of ICE. So ICE, ideas. So what do you think is going on? Or what have the other doctors told you? So you can see here that the questions are open-ended questions. They can't be answered with a yes/no response. Secondly, what are the concerns? And so this is then trying to go to a deeper level, not at a practical or, this is the test, or this is my symptom, or I've got pain in this spot, but actually what is happening to me at an emotional level if I'm the patient. What am I concerned about? Or what do you think this means? And then their expectations. So what are they hoping to achieve out of today's discussion with you, or over the next few days, or in this hospital admission? So once we have a sense as to where their mental situation, what their thoughts are about what is happening to them, we might be in a situation where either they have already realised that the cancer has progressed, or the treatment options are now no longer there for chemotherapy. So that's going to be an emotionally difficult situation for them. That's going to be sad or upsetting. or it may even be unexpected. So they may be expecting you to say, we can give more radiotherapy or we can do that operation, whereas actually what you now need to say to them is that we can't do that treatment. And so we've already got the answers of what they're understanding. And so first of all, we need to acknowledge it. So I hear that you are wanting to have more chemotherapy, or I hear that you're worried about whether transfusions are an option. And then you can say, well, I hope that is the case, or if you already know the answer, I wish that we could be doing this, but I'm worried that we can't. And so that three-phase approach of I hear, I hope, and I'm worried brings them away from where they were initially at the start of this conversation through the ICE questions of what their ideas are, what their concerns and expectations are, and then hopefully reframing it towards where you need the conversation to go. All along the way, this is then the third component of the difficult conversation, is that we need to be empathic. So allow them to express their emotion, even if it's an emotion that makes you feel uncomfortable. So you may be someone that is not comfortable when people are crying, but if the tears come, especially because of the information that you have given them, one of the things that we should do is not stop that emotion. Instead of saying don't cry, because often what we say when we don't cry, we will then follow that up by saying everything will be all right, where unfortunately that is not the case. But just allow the emotion to come out, because it's only once the emotion has been able to be expressed that then their mind will eventually, after a while, hopefully a short while, their mind will be clearer, and then they will be willing to hear what you have next to say. So make empathic statements, and I'll expand on that later on. And then our non-verbal cues that we give them. And certainly one of the journal articles, the Spikes article, does give some guidelines about that. The next stage then is investing, the final stage is investing in the end. So we go back to, well, what was their original concern? And very often there will be a temptation in these conversations to talk about specific things, whether it might be what the hemoglobin is and what we're going to do about that, or what has the scan shown and are we going to do an operation. But we can talk about those things, but always trying to bring it back to the values that the patient or the family member has given to you. We summarise what we feel are the agreed outcomes, and then plan for our next steps. So it will be maybe something along the lines of, well, I will see you tomorrow, or it may be that we will now give this treatment 3 days and assess to see whether it is working or not. But always they're clear on what is going to be happening. It's always very important to conclude by asking what questions that they have got for you. So ideally, again, not a closed question. So not, do you have any questions? Because often patients will, or their family members will just respond by saying no, nothing, but rather what questions? So it encourages them to actually say what's on their mind. There are common traps that we all are guilty of, and absolutely, I still make some of these mistakes even now, because we're all human and we do make mistakes. So we need to be aware that there is a power imbalance between us and the patient or their family member. So it's not easy for them to raise the discussion when things are worrying them or if they're concerned about things. And so that's why having that ICE part of the conversation where we get, well, what do you think is going on? What are their concerns is important. Always making sure that you've got the time. And so if you genuinely don't have the time for this conversation, it is best to leave it for another opportunity. being ill prepared. So even in the work that I do in the hospital where I'm working, I will regularly, sadly, see doctors go in and they haven't actually looked at the blood test beforehand or seen the scan results. When I say here wanting to jolly them along, that's the problem of false reassurance, saying it'll actually, everything will be okay, you'll be all right. These are the phrases that we really want to try to avoid. Closed questions, I've already mentioned. Saying to the patient, I understand. Well, sadly, unless you yourself have actually been in that exact situation, and even if you have been, your own experience of that will be different. But saying I understand is not a helpful comment to make. And then, as mentioned before on the previous slide, if the family member or the patient is drawing you into technical aspects, we should also avoid going to that safe space, because we're all often very familiar in talking about blood tests or drugs or treatments. So tell me, you know, if the patient is saying that they're worried and they're not sleeping, and then we could respond, well, so tell me, what's happening with your pain at night that is not allowing you to sleep? But more actually, what are you worried about? What are you thinking? A helpful question that I will often ask is, often at night people will, if you know that they belong to a religious faith, I will ask them, well, in the middle of the night, what do you pray to God? What do you ask for? So specifically then, if we already know that we might be dealing with a situation where either the patient or the family member is angry, beforehand we want to prepare. So we want to make sure that we know the facts of the situation. I think all of us in the APLI team are aware of the limited opportunities for privacy or being able to remove yourself from other people. But if there is any opportunity to sit in an office away from everyone else, that's very important. Involving other people, so having a nurse stand with you. So that's partly so that then they can follow up the conversation, but also so that you've got someone supporting you, because these are not easy discussions. We're always needing to be aware that absolutely we're human as well, and so if someone's angry, it is almost the normal response that we will become angry back at them. There are certain triggers that people will find that are particularly hard for them, the situations that they really want to avoid. And so trying to know what are the things that are particularly difficult for you to handle, just really so that you can acknowledge it and say to yourself mentally, yes, this is going to be a hard discussion. This is what I find hard about it. The principles will always be the same, but it very much, obviously, there are certain rules when you're dealing with someone who is angry. Allow them to express their emotion, but within clear limits. Naming and recognising that they are angry, but trying to find something common that we can agree on. And if what you're doing is not working, if the anger is still there or if it's getting worse, then you really need to stop and think, well, what can I do that may be different? And if you, hopefully in that situation, if you have another person with you, maybe then it might be even just that you step back from the conversation and you allow the nurse or the doctor just to say a few things, just so that then, even then, you can calm down yourself and think about, well, what am I going to do? Time-limited trials are talked about very frequently, but we do need to be clear about, well, what is the time span that we're going to give this extra treatment for, and what are we looking at as the outcome, and ideally something that we can all observe and agree on, rather than something that is subjective and then may result in further disagreements. So after this conversation, it's always important to provide that handover to the rest of the team, just because I think that they will need to know what next needs, what may happen the next time they interact with the patient, but also you might need to just ensure that you're supported as well. So the generic communication skills, so the non-verbal cues, so making eye contact, having that relaxed body language to indicate that you are listening to them, the open questions, showing empathy, but just genuinely being able to be respectful and hopefully caring. The final slide that I have here is then how do we respond to the emotion that may come up? And this can be used for any of the emotions that we see, whether it's someone who's crying or someone who's angry, someone who is actually behaving irrationally and they are moving from one emotion to another, someone who's having anxiety or clearly having a panic attack. Naming it, just actually saying, I can see that you are angry or very sad. And so the important aspect of naming it, it actually just shows, first of all, that you're human as well. Because if you don't even just respond by saying, well, I can see that you're upset, the person who is experiencing that emotion may think, well, I don't even know if the doctor understands what I'm going through. So secondly, understanding. So why is it that what is it that is making you cry today? And it can feel like a silly question, but sometimes these just ways of just trying to draw out additional information. Showing respect, and only appropriate, if it is appropriate, showing or giving reassurance. Supporting them. No matter what happens, we will still look after you. So what we want to try to do is completely remove from our vocabulary the phrase, there is nothing more we can do. There is always something that we can do. It may only be something as simple as, well, we will continue to listen to what you're saying and try to manage your symptoms, but we will be here providing that support. Exploring it. So can you just help me to understand what's making you angry? And silence. So when a person is crying, sometimes, although you may have those other options in this acronym to ask, other questions to ask, sometimes actually just allowing the emotion. So I would just like to stress, however, that you don't have to use all of these techniques, and you may find that just using a couple is actually sufficient. Choose what is going to work best for you, though. Okay, I'm going to stop the share screen function and come back to the group. So, Odette, can I just check whether or not we should pause for a moment just to see if there are any questions just about these theoretical concepts, and that the whole process of having a goals of care discussion and using our knowledge as the medical expert, but also getting the patient or the family's perspective as the expert in them. So yeah. Just if you're, sorry.
I think it would be good to open up to the group and check in on how people were thinking about that. You know, what came to mind from your presentation. I think we've got time to do that. I'd love to hear some comments from the group if there are some, because I think you know, I can, when you were talking about the mistakes that we make, I think a mistake that I fall into often is this giving too much information and getting caught into that. And I think that's quite a common sort of trap for doctors, maybe for nurses too. We can hear from the nurses, but certainly to we can get ourselves into quite a corner sometimes, trying to avoid the emotion by giving a lot of information.
And I think, Odette, there, the important thing that you've raised is that we all go back to our comfort zone. And if I'm a doctor, my comfort zone might be medical aspects. Or if, you know, you're a pharmacist, it might be the medicines, or if you're a nurse. Whereas trying to take the conversation to that deeper level, away from the disease model, and hopefully understanding things from their perspective.
Would anyone like to share something, or make anything come to mind that you'd like to share with the group, or ask Dr. Anil?
Can I say it? That I mean, this as a theoretical concept, in particular, the process of ICE, so the ideas, the concerns, the expectations, that is not something that comes naturally to me. And if I look at my practice over my career as a doctor, very much, I've spent the majority of my time when having difficult conversations just remaining at a very superficial level, just only talking about the disease and not getting to this deeper level.
Are there any questions?
Please go
Sorry.
ahead. No, go ahead.
I was about to ask, are there any questions that anyone wants to ask, or any comment or any experience that they would want to share with the group? No, yeah. Yes. So that's about GCRI's camera is not working, so many of them are joining. Do you have any comments, the team from GCRI? Or any questions?
Was fantastic talk, and nothing to add in. And there is no question also.
So, Odette, should we then move on to the role play?
I think we could do that, and just a reminder to people that if you would like to use the chat function, please do that too. If you're having trouble with the audio, or just would feel more comfortable using the chat. And we've got time to have more discussion in the breakout groups as well, which I think will be easier than in this larger forum. But I think, you know, Dr. Anil's given us a really lovely, you know, framework to think about. I mean, I'd wonder if people are familiar with some of the framework, this nurses mnemonic. Have people seen that before? Is this new? Maybe you could wave your arm if it's new, or shake your head if you know about it already.
Odette, there's yes, there's some people indicating. There's a very good question from Vizag, which is how to help the caregivers to communicate with the patient.
Okay, very good. Shall we can let's talk about that.
And so I think that is yeah, a very significant problem in any culture. And sometimes there can be it's almost like that there's a dance that goes on between the patient and the caregiver, so their family member, where each of them seems to be circling around the other. And so the patient may be, in their minds, experiencing certain emotions or being worried about something, but they will have this desire that they don't want to upset their family member. They don't want to make them worried. At the same time, the caregivers themselves may be thinking, I can see that my loved one is becoming more unwell or is having these problems. And I'm just so sad that I understand that they're dying, but I don't want to say it. And they don't want to open up that conversation because by bringing it out into the open, they worry that that will upset their loved ones. And so very much trying to give the caregivers the permission to have this conversation. So just like there are the same traps that doctors or healthcare professionals can fall into when talking with the patient, all of them really apply to the family members as well, that they may want to jolly along the patient and say, actually, everything will be okay. Or they may, when something serious is raised, they may just very quickly divert the conversation to another area. And then sometimes even just relying on the patient to raise the problem. And so it may be that we just need to say to the family member, in our role as the doctor, it perhaps might be important for you to open up with your mother actually how you're feeling, and just, it will be hard, and you may cry, she may cry, but allow her to give her this opportunity to have this conversation with you. So encouraging them to someone, whether it's the caregiver or the patient, to take the first step.
Thank you, Anil. Would anybody else like to comment on that as well? I don't know, David or John, or even, I don't know if Dr. Vidya is there in Vizag, but I think the beauty of this Hamrahi Echo is that we can, learn from each other. So please share your experiences.
Hello, Adit. Thanks, I'm here. Hi.
Hello.
I'm just sitting with a big group, so not completely visible.
Hi, Vidya.
Hi, Adit. So that question was actually from one of our counselors. She wished to ask that. And thanks, Dr. Anil, a lot of the things that you said. Sometimes what I feel bad about is the sheer numbers of the patients that we see. So I think our biggest constraint in our situation is, however much we would like to use all or most of that, we do find the constraint of seeing so many patients in one day and in crowded rooms really challenging. So I think that's where, having said that, that's no excuse, but still.
But Vidya, sometimes I think that makes you absolutely the most expert communicators, because so much is communicated non-verbally.
Yeah.
And if you have an attitude of openness towards the patient and the family and want to connect and want to, communicate it in this deeper level, I find that some of my Indian colleagues do it, and I would suspect you do it incredibly efficiently, actually, and are very skilled at doing this in a very rapid sort of way. David, you look like you might want to say something on that. I don't know. Am I misinterpreting your body language? But it's certainly something we're very aware of, that that's why we really need to hear from you in India of how you...
I think that's where what Dr. Anil mentioned about investing early and investing late.
Right.
I think that is the key, because early palliative care, when we get our patients right in the beginning without much of a symptom burden, that's actually the most valuable time. And once we do that well, it has helped us to bond. So irrespective,
you have that
of the
trust,
fact, and that trust comes in right there. So that is what we have found very useful. that
Yeah.
early pal care and, use the day that you have. You may not be able to do it with all patients on a single day, but with
Yeah.
some patients, we stagger it that way. So that's how we usually manage.
You have that foundation. Yeah. David, you were, and then Iqbal, I know.
Yes.
Hello,
thank
madam.
you.
Hold on, Iqbal, Dr. Yeah, thanks.
Well, thanks, Odette. Very brief comment. I think everything depends on the trust that exists between the patient and family and the doctor. Everything. So the quicker we can develop that and make it the reality, the better off we'll be. So small acts of kindness, generosity, anything that you can do to put a relationship between you is gold in terms of creating the relationship that would allow you to be accepted and allow you to be trusted by the patient and family. That's all. Thank you.
Yeah, I couldn't agree more, David. Iqbal?
Hello, good afternoon, madam. At the very outset, I would like to thank Anil sir for his beautiful presentation. It was a very refreshing presentation, and I could learn many new things, especially the NURSE acronym for the managing, eliciting the problems of the patient. And as what Dr. Bidda says, truly that we are a busy OPD, we have less privacy. But I use something, to tide over this situation. What I do is that I see about some 25 to 30 patients per day. And amongst these patients, suppose there will be new patient to me, at least 3 or 4. Other will be follow-up patient. So I make sure that the patient whom I have not spoken nicely about the diagnosis, prognosis, communication, I take little bit more longer time. I make sure that I've spoken to them once very nicely, and rest of the patient I don't speak too much. So in that way, I save some time. Also, I can convince the patient also.
Yeah.
And
Very
also,
good.
I have seen that unlike Western countries, I have been to MD Anderson also, where you give lot of time for each patient. One patient, they will be spending around 30 to 40 minutes, I have seen. We sometimes used to get bored, what they are doing, so long time, So, but these are very good things, and this should be practiced. What Tandon sir has today I have told, these all things are being done there. I have seen in a very strategic manner. But here I have seen that in our continent, in our country, most of the patients, there is collusion. They don't want the patient to take the decision. They always guard their family, the patient, So in our situation, I think giving information to the patient should be tailored according to their receptive capabilities, like the educational background. And so some of the patient, even if you tell, they don't understand at all. They will say, they don't understand what is disease. They just want to know about their pain and other things. So such, we should not break too much of head in giving too much of scientific, as sir told, in giving to such group of patients. It should be tailored according to the need of the.
Absolutely. I think that's a very
Thank you,
important
madam.
point, Dr. Iqbal, that it needs to be carefully tailored to the individual situation. Anil, do you want to make any other comment? I know there are a couple of other questions in the chat and time's ticking on. So shall we just look at the other two questions quickly, or did you want to make another comment about the discussion we've just had?
No, I won't. But the question there is any tips regarding teaching communication skills. So I think that the evidence tells us, sadly for me, that didactic presentations like I have just given, they actually are not effective. Really what it does require is actually taking these skills and practicing them and receiving feedback. And so one of the actual techniques that I use here in Perth is that I will just, on a ward round, when I've got students with me, clearly I don't want to put them on the spot to have this conversation, but then afterwards I will just say to them, so just give me some feedback on what you saw me do. What did I do well? What could I have done better? Just so that hopefully they can start reflecting on the words that they and the skills that they may use. The other question is sometimes the caregivers do not want to communicate the diagnosis to the patient. How to effectively convince the family regarding this. I think that, to be honest, would be a complete other presentation or session in its own right. And in no way would I want any of my presentations so far to suggest that we should be breaking collusion if we think that that will be harmful, or that we should be going against the wishes of the family. So these are just general principles that I've been talking about here. And I think that very much, I think all of our APLI Hamrahi team are aware of the cultural differences that you are dealing with, and that, yes, what may be done in Texas or in Australia is not always applicable, but there may be just small components that can be used.
Thank you, Anil, and thank you, everybody. And please keep up the chat and the comments and so on. That's what's going to make this Hamrahi Echo something valuable for you all. So great job. So shall we go on to the role play? Anil and David, are you ready to role play your sessions, international role play, and all of us will critique you mercilessly on.
Please do. David and I, we've got nice thick skin. We're happy to receive anything, and as we say in Australia, we'll give it a red hot go. So
I think you're taking one for the team by doing this role play, and we're very grateful to you. Okay, everybody, let's enjoy. So the first one, I think, is a not so good example. Is that still the plan?
Yes, yes.
And then you won't leave us in that excruciating state too long, and then we'll do a longer one, which is a better example. Sorry, Anil, you were going to introduce it. Go ahead.
So the background is that I'm the doctor. David is the father of a 14-year-old girl who is dying of cancer. David is a successful businessman, and he spent a lot of money looking after for the treatment on his daughter, but has now been told that nothing further can be done to treat the cancer. And he is angry because he feels that we, the doctors, have failed him. So, hello, David. How are you today?
Doctor, very well, thank you.
So I think that what we need to do today is just talk about what we are going to do for your daughter, because as I told your wife yesterday, there's nothing that we can do for her anymore.
Yes, that's what I heard. Thank you, Doctor. I heard that my daughter Anushka, having been treated for so many months for her leukemia, has, at least in your opinion, reached the end of her treatment.
Not just my opinion, but in the opinion of everyone else as well.
Okay, but in essence, she has no longer the capability of having any more chemotherapy. She is not to be transfused anymore. And as I understand it, she's been referred from the specialist hematologist looking after her to you. And I don't see
they can't do anything
this
more.
could have happened without my discussion or approval. I'm very cross about it, frankly.
Well, but we don't need your permission for that.
Well, very good. Well, let's be that as it may. You can be sure that I'm very angry, and I will do whatever I can to make sure that this decision has been overturned. Will be overturned.
But the decision is final, and we actually just now need to look at how we can care for her because she is dying.
Yes. Well, again, I say I'm very unhappy about the way this has all been done. I'm unhappy about the response of all the
But
doctors.
you can take your anger. If you're unhappy, you can go and make a complaint to the medical superintendent. I don't have time for that.
Well, very good. Well, that's exactly what I'll do. And thank you very much for your candour, Doctor. Goodbye.
Okay.
All right. So well done. How do you both feel after that encounter? Can I ask you, David, how you feel?
Well, I'm very angry. I mean, this doctor has taken it upon himself, it seems to me, to make a decision that my daughter should not receive any more appropriate anti-cancer treatment. And he's not willing to talk to me about it. He's not willing to discuss it with me at all. He's just telling me what's going to happen. And I think that's essentially an abusive behaviour and not something that I would expect from any competent doctor in this culture, in our society. I'm not happy about it at all.
Thank you, David. And Anil, how did you feel about that encounter?
I thought that David was very annoying, and the reason why he annoyed me, I got a little bit angry, but more annoyed was the emotion that I was experiencing, because it was as if he wanted to be the one making the decisions about the referral and what treatment should be given to his daughter, whereas actually, no, it's the haematologist and my decision.
Okay. All right. Thank you both. Can I ask the community, I won't say the audience, the community for some feedback, what you noticed in terms of, thinking of Anil's presentation before, what you noticed by way of poor communication, because clearly both David and Anil feel very antagonistic towards each other, and there was no connection made at all. So what were some of the ingredients that led to that sort of lack of communication? Please feel free to put it in the chat or...
This is Dr. Koshi.
Yes, Dr. Koshi, thank you. Sorry, I can't see all the, so thank you for speaking up. Yeah.
Somehow I felt both of them never were in the same page at any moment.
Mm-hmm.
Probably the doctor was abruptly cutting off the patient's father before hearing the father completely, because I don't know what the conversation would have been before this particular one, but what came out of this conversation was that the doctor was a bit impatient and had his own thought processes beforehand itself, and therefore somehow the conversation went into a rough patch.
Exactly.
It could have been better handled.
Beautiful. Yeah. Thank you. And others have mentioned the lack of respect, the fact that Anil interrupted David and didn't listen, as Dr. Koshi also said. And then Dr. Catherine mentions the lack of empathy. There was no empathy expressed by the doctor. And Minu says the doctor just wanted to finish the conversation, that his decision is final. So, and also that terrible phrase, nothing can be done. The doctor said he was busy. Shri, you demonstrated the don'ts beautifully. So shall we move on to the do's then? Shall we have a healing encounter rather than that rather fractious encounter? David and Anil, are you ready to do another take?
Absolutely, thank you.
Sure.
Thank you both.
Hello, David. My name is Anil. I'm not sure if you would remember. I'm the doctor looking after your daughter.
Yes, Anil.
It would be nice just to have a chat about what's been happening for her lately.
I would appreciate that because I've been pretty cross about what's happened.
Okay, I'm sorry to hear that. So maybe just to start with, it would be just good to understand what you have been told by the haematologists.
Well, not much, to be honest. The haematologists have told me that they were making a referral to you because the treatments they'd been giving my daughter, which they've been giving my daughter for many, many months, are no longer appropriate. And I really am not certain whether or not that's because they feel that the money's run out or that I'm no longer able to support her care. But in any case, that there's no further chemotherapy, that there will be no more transfusions and no more reviews by them, but purely reviews by you. And truly, I don't know what you do. I don't know what your role is.
Okay, so David, you've mentioned a few things there, and I will do my best in the time that we have got, because I'm sorry that I don't have a lot of time today, but this can be just a conversation that we have over a few occasions, if that's all right. And you've said a few things that I will try to cover. One of the things you said was that you haven't been told much. Now, because the haematologists have asked me to get involved, I would like to be the one explaining things in more detail to you. Ideally, yes, it would be good for them to talk with you, but I think that that may not be realistic. The other thing that you also said was that, yeah, you're angry. What do you mean by that? What are you angry about?
Well, I think that I'm entitled to be a bit annoyed about the fact that the apparently successful treatments my daughter has been getting from them have been stopped without any adequate explanation.
Okay, so you actually thought that the treatments were working?
Well, at some levels they were. The transfusions were effective each time they were performed. The chemotherapy seemed to be providing her with some control over the leukemia. Yeah, I think there were some aspects of her care that were being effectively managed, yes.
Is it possible, though, that there were some aspects, or that maybe you were seeing things that were not going well for your daughter?
Well, yes, I have to admit there were some things I was very concerned about. The fact that she's still losing weight, having less energy, and less interested in what's happening around her. All those things were concerning me before this referral happened.
And what were the explanations that you had for those changes that you saw?
None.
What we are hearing from the haematologists is that although there had been initially a good response to the treatment, that hasn't been the case lately. And over some time now, things have actually gotten worse and the disease is actually not remaining under control. And that's where palliative care, where our role should be considered. And I think that not everyone is familiar with palliative care, but our role is to support you, to support your daughter, really with the understanding that we need to focus on her quality of life.
Do you mean by that that I should simply accept the fact that she's dying?
I think that as a father, you may always want to fight against that horrible reality.
Yes, that's right.
And it sounds like you've done everything in your power up until now to try to prevent that. I've heard that you've spent a lot of money and that in your business, you've been able to earn money that you've spent on the treatments for your daughter.
Mm-hmm.
That
Yes.
that in itself can be very hard.
I'm not concerned about the money. I'm concerned about my daughter's welfare.
And I accept what you're saying, but do you mind me asking, how are things going financially for you?
Well, they're not so good as they once were because of the amount of money I've been spending. But I don't feel badly about that. I'm perfectly willing to try and spend as much as I need to spend to support my daughter.
And although absolutely money can buy or purchase a lot of treatment, even for the richest person in the world, money is not the answer always.
Well, I understand that too, yes.
Tell me about Anushka. What is she like?
She's a delightful, introspective, kind, 15-year-old girl who's ignorant of the world at large, but has been a wonderful and gentle member of our household for that time, for 15 years.
She's very weak at the moment, so she's not able to get out and play with her friends anymore or go to school, is she?
No, she's not, that's right. But she's
So-
nevertheless still got a good brain, and any of our conversations here, I should think, in the terms of decisions, she might like to have some involvement with.
So with that good brain of hers, what does she do? How does she spend her time?
She's very musical. She's very interested in classical Hindustani music. She's started to learn the sitar 2 years ago. You know, she is a very cultured young girl.
So with this move to palliative care, because sadly we do need to accept that the haematologists don't have further treatments that they can give her. And I think that there's not a person in the world that would want the situation to be as it is, but we need to accept that they have done the best they can. What are you hoping for now?
Well, of course, until this conversation, I was simply hoping that we could continue with her treatment and that she would be cured. But I have a sense that you're moving me or trying to move me towards a point of acceptance of the fact that that's not going to happen.
And I think that I hope that, or I would have hoped that we weren't having this conversation, but we do need to plan for the next stage, this final stage of Anushka's life.
Then I think perhaps if you're willing to give me the time to talk to you and to my daughter and with my wife as well, we might be able to work out some solutions around that. Would that be, are you able to help us with that?
So I won't be able to do that today, but certainly that is something that either myself or the team that I work with, because I'm only one part of the team, we can do this.
All right. Okay, well, let's, if we can, do that for the moment and see how we get on. Is that all right?
Yes. Before we go, David, what other things did you want to discuss today that we haven't covered?
Well, there are very many, of course. So many things about how we might care for her if the treatments aren't effective. And of course, my main concern is to reduce her suffering as much as I can and to help her to understand her place in the world and to reach some understanding about why this has happened to her. I don't believe I'll find that answer, but perhaps if I work with her, we can find an approach that might perhaps give us some solutions about that. So my suffering is my concern, that she has as little as possible.
Do you think that she's suffering at the moment?
Yes, of course. And I don't think that you or I or anybody else can stop that completely, Doctor, but I would hope that we can minimise it.
David, thank you very much for being so open and sharing your thoughts with me. I'll see you again.
Thank you, Dr. Anil. Thank you. Bye.
Thank you both very, very much for a great role play. It's so many elements there that I think, can reflect on, and maybe we need to do that in the breakout rooms in a minute. But Anil and David, would you like to maybe just give some feedback yourselves about the role play and how that felt for you? Maybe David first, as the father.
Thanks, Odette. I think always when I do these role plays, I become too involved in them, really, and start feeling too many feelings that are not ultimately mine. But
Yeah.
I do think these role plays, for that reason, are really important. That, you know, we tend to think of them as being somewhat trivial learning exercises, but actually they're tremendously powerful. So
Thank you very much, David. Thanks for, that was a very authentic, you know, I think we were all feeling for you watching that role play. So thank you, David. Anil?
David, you're absolutely right. It's, you know, for you and I, that was a very powerful experience. And so what I felt desperately sad. But interestingly, through the conversation, it actually almost felt like you were leading me rather than me leading you in a particular way to get a certain outcome. It felt like, yeah, that you were actually doing more of the hard work than I was.
And that's often the way, isn't it, really? If we just stand back a little bit as clinicians and allow that to unfold. Thank you both very, very much for the role play again. And shall we, Raju or Pali and team, shall we just go into the breakout rooms? I'd love to hear, for everybody to have some chance to reflect on what they saw during that discussion.
Yes, would you want to tell them what do you expect them to do and how much time?
Yes, I think time is getting a little away from us, but I think that's okay. We have an outline of time and we can play with it. So the idea was maybe 10 minutes in the breakout rooms and 20 minutes for discussion, but we don't quite have 30 minutes available. So let's still aim for about 7 minutes in the breakout rooms, and then the rest of the time for feedback and discussion as a wider group. And is there a slide with some points to reflect on?
Odette, I'm just typing those questions in the chat.
All right. I think Raju was going to do a slide. I'm not sure if she had a chance to do that or not. But can we still see the questions in the chat if we go into the breakout rooms? I'm not sure.
Yes, maybe we can take the questions in the chat into the WhatsApp group so they can just go through the questions, or they can look it in the chat again. So we allot you to different rooms where there will be one faculty from Australia and the other participants. You can choose one person who can write down the discussion points and present it to the larger group, because there is no time for everyone to present the idea. So someone just summarize what you have discussed in the last 7 minutes and keep it very short. Just summarize the points and discuss it with the larger group. So you will be getting a message on assigning to groups. So please click permit or yes to those requests. We'll assign you to separate rooms right now.
Thank you, Shreya. That's great. Penny. Do you know Dr. Rita? Dr. Rita, do you know Dr. Carl? You're almost neighbours. You're almost neighbours. Dr. Rita's in Bihar, in Patna, and Kachar is in.
So please, Catherine or Sharina, please speak up and let's start this conversation before all the time goes away.
Time. If we cannot abruptly say a difficult conversation, or we cannot just do the difficult conversation all of a sudden. That's what I personally feel.
Thank you. But obviously, as was already said by someone else, in India, you've got so many patients.
Yeah,
so,
that's a major difficult part.
Of being in control of the whole piece, that where at least doctor is allowing him to be in control of what can be done now, and they will be there. So I think when rest everything is falling apart, just to allow that thing that you are in still control to take this reality in the way you want. I think that was
from our hand. Definitely, then we can spend time.
Yeah.
To effective communication.
Bhavna,
Sir, in continuity, this how we manage the time. We delegate the work. We send the patient to counselor or sitting nursing with our nursing staff, and that way we have to manage too many patients. And one more question: what done well in that conversation? I think what was done well. So doctor introduced himself in the beginning of the chat conversation with patient relative. That was a good part.
do you, in your work, do you have names?
Yeah, I will take the notes.
Thank you. So there are also a couple of questions. What was, if we just think of that role play that we just saw, what was done well? What communication skills, techniques did we notice? And what phrases or questions might you use in a similar situation? What seemed to work for you?
I'll start. I think Anil was very good in the second one in that he asked David about how he saw the situation.
Suffering and what could be done.
Yeah, that's a really good point. I hadn't picked that up myself, but thank you for that. So Nanda, do you have anything to add?
I just wanted to share that when we compare the first role play to the second, so the second was like, a lot of pause and a lot of patience, doctor was quite patient, and his tone, which is actually plays a very important role when we talk of communication. The tone was quite good and very appealing, and maybe the patient's father was quite comfortable in the second role play. That's what I felt. Thank you.
Lovely. Thank you. So Rita, are you there? Would you like to comment?
Yes, sir. I think doctor gave enough time to the father. So
A little bit more.
yes.
I understand a little better what has happened.
Yeah. 'Cause, 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 'cause,
Can any of the other people hear me? Mukul, Path, are you there? Tips Echo, are you there? Hello?
Yes, 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 please.
Are you just observing or contributing?
We are just observing. We are getting into all the rooms and checking whether everyone is discussing or not.
Righto, okay, thank you. Well, Sharina, let's go back to you because you're the only other one talking to me apart from Catherine. Do you think that that I have reached a complete acceptance about what's happening?
So we can start from the group one. The person who has noted down the points or who is going to present, you can just shortly summarize what have been discussed in your group. Anyone from group one or the one representing group one. I hope you all know which group you belong to.
But Bhavna, I think we were in group one. Do you mind relaying our discussion?
We discussed, Anil sir asked what if patient is angry and then how to deal with. So Meenu was saying that if too many patients are there, then too much time to give too much time and deal with shortage of time. For that answer was that we can delegate, learn by practice. We can make that in every point to be covered for a better communication, but be in little bit speed. And one more thing, what I feel, we can delegate the task, ask a counselor to deal with nursing, can take help of nursing staff also. So more patient we can cover. And to deal with anger of patient, we should make him calm, comfortable, ask for water even, ask for better comfortable sitting, and then see the case file properly, listen. First of all, listen the patient and relative carefully, and after completing his anger and his talk, explain properly. Is it?
Thank you, Dr. Bhavana.
Thank you.
This was group 3. So group 1 is Odette's group.
Okay, Dr. Rita will talk back. Thank you.
Thank you, Dr. Odette. Actually, the discussion
Can you speak louder, Dr. Rita? Your voice is very low.
Oh, okay. The discussion point in my group was...
Dr. Rita, you are not clearly audible. Can you keep your microphone near to your mouth?
Hello, now am I audible?
It's very, very low voice.
It changed during the breakout group. It was quite good initially. So I don't know if it's the mic.
Would you like to change, remove the microphone and try talking?
Hello, am I audible? Hello. Hello.
You
It's a
are,
little
but
bit.
yeah, very low voice.
Sometime leaving, you please leave and rejoin again. It sometime works better.
Can you, am I audible now or should I? Hello.
Yes.
Yeah, so the discussion point in my group was about regarding the role play, what went well. And I think all of us agreed that the communication started really well. Though it was quite long and exhaustive, the doctor used the technique ask, tell, ask, asking some question in bits, clarifying it, and then again further asking questions. And there was a sense of non abandonment,
That means every time the caregiver was being assured that every help will be given to him, and the doctor was giving honest opinion regarding whatever his queries were, and he also clearly told that he may not be able to entertain all the questions, but his team will be there to take care of him. This is what we all discussed.
Thank you, Dr. Rita. And there is a comment from Dr. Anil telling about the ask, tell, ask for mentioning or discussing that point in your group.
Thank you.
Thank you, group one. And, group two had, I think it's David's group, David, Catherine, Mukul. Someone from your group can summarize what you were discussing in the last 5 minutes, 7 minutes. David, we can't hear you. You're on mute.
Dr. Sharina might be willing to do that, but we didn't have a lot of time.
Absolutely. We were able to acknowledge some of the strengths in the communication encounter. We felt that in the second encounter, Dr. Anil took the time to understand the father's perception of the situation. And in doing so, what we know he also was able to do was assess this father's information needs and also observe the underlying message begin to emerge behind his emotion of anger and distress around the situation. We didn't have time to discuss a lot further. We were beginning to explore whether or not we felt the really challenging question of from the father of, are you asking me to accept that my child is dying? We were going to explore that part of it, and I think that would have been really valuable to look at other ways of responding there, whether with silence or other phrases, because that was a standout, really challenging question that I'm sure elicited a lot of emotion for both the father and Dr. Anil.
Yeah, thank you.
Thank you, Dr. Sharina. And is there one more group, group 5? Oh, sorry, there were only 4 groups, I think. No, I think there is John's group yet to come back with feedback, or have you already done the room 4?
Sure. Shalini, would you like to feedback? Or are you happy for me to? Either.
I think you go ahead because I've not listed down the other points. Sorry.
Thanks, Shalini. So look, we covered fairly similar points to the other groups. That Dr. Anil allowed the father to take control in the conversation. And one important one that when
John, your microphone is muted right now.
Sorry, I must have accidentally muted myself. So yes, when Anil mentioned he would have hoped he didn't have to have the conversation they were having, that the tone of the whole conversation changed after that. The father was very comfortable, and the doctor gave enough time for the father to express his wishes. And I was going to ask Dr. Ali, he was in mid-sentence when we finished up, but it looks like he's not in the room at the moment. So yes, that's us. Thank you.
Thank you, Doctor. Thank you, John, for your summarizing for your group. Audit, would you like to give a feedback or just some closing words because it's 3 minutes to 4:30. You're muted right now.
Thank you, Sri Devi, and thank you everybody for entering into this so generously and sincerely. As David said, doing the role plays, it's a very rich way of learning, and Dr. Vidya had hoped that it proposed that we all do role plays in the breakout group. So in your feedback, it might be, I'd love to know whether you would be open to trying that at one of our later sessions. If we're going to be able to continue with this Echo Hamrahi program beyond the initial 6 or 7 months that we've set up, that's one of the possibilities as we sort of grow in confidence with each other, that we might or be willing to try role plays in the breakout groups. So please give us your feedback on that. I'm sorry we didn't have more time to discuss the role play in more detail, both in the breakout groups and now, but hopefully this has stimulated some useful thoughts and discussions for you amongst your teams. And I guess time is against us. We have 1 or 2 minutes. Please leave any other comments in the chat and in your feedback. And a reminder that we're to meet up again in February, on the 8th of February, which is quite close to the Indian Palliative Care Conference. So hopefully you can still make it to the session and we can continue our conversations. There's time for any last comments from you, Shri, or anybody else who would like to make a last comment, please do. Otherwise, we'll see you in a month's time. Shri, do you want to say anything?
I was just maybe as a closing statement, I was remembering Dr. Biju's way of teaching how to deal with anger. So he always relates the emotion, anger. Managing anger should be like a procedure where you're actually doing an ascites tapping, where the tummy is full of fluid, the tummy is tense. So you literally need to put a needle and drain the whole thing out. So he always compared dealing with anger to that procedure where you're actually providing an outlet. Let them drain all the fluid, all the emotions to you. Be calm and quiet, wait till the tap is dry, and then you start talking to them. So that's something which doctors can very well relate to. And when we think about it, it's exactly the same. You're actually allowing that fluid or the anger or emotion to come out completely, and then you start talking to that patient. Yeah, so that is a wonderful session today. And I think everyone got some time to talk to each other, at least in the breakout rooms than in the larger groups. And thank you, Anil and David, for that wonderful role play. It's not that easy to do role plays because, as you were telling, you sometimes get into that, get connected with that, and then you sometimes feel that emotion. So that's slightly difficult to do. Thank you so much for doing that for this group. Yeah, that's all from my side.
Thank you. All right, everyone. Well, good night from us, and we'll see you in a month's time. Take care.
Thank you all.
Thank you.